to the heart. The mediastinum has subdivisions, of course. If you draw a line through the angle of Louis, kind of like we did yesterday, and I said that it goes to the top of the heart, so that divides the mediastinum into superior and an inferior compartment. And then the inferior compartment is further subdivided into an anterior, middle, and posterior compartment. And you need to appreciate the contents of each of these compartments when you're trying to interpret X-rays and CTs and things like that. If you don't know the anatomy of the compartments, then you're just lost. In the superior compartment here, the superior compartment here, the great vessels would include the arch of the aorta, the subclavian, the brachiocephalic, the superior vena cava, all the big vessels coming in from the upper extremity of the head. The thymus gland in kids, and I'll show you an example later on. The esophagus, cranial nerve 10, trachea, phrenic nerve, left recurrent, and the thoracic duct. We're going to see the thoracic duct today. In the inferior divisions, anteriorly, as you saw yesterday, it's mostly just fat. There's some lymphatic tissue in the area, but mostly what you're going to encounter is fat. The middle contains basically the heart, the pericardium, the great vessels as they leave the top, and the inferior vena cava as it comes in the bottom. You'll see that later on. That's where the trachea is going to divide into the bronchi. Remember I said the trachea bifurcates at the angle of Louis, so you're going to have the bronchi down here. A system of veins called the azygos vein, and we'll talk about that in a minute. And of course the phrenic running down the lateral aspect of the pericardium. In the posterior aspect, it's mostly just things that are running from top to bottom, including the esophagus, the aorta. We also have cranial nerve 10, which is headed towards, which is going to be wrapped around the esophagus at this point. The thoracic duct. And then there's another thing we're going to find today with the azygos system, but there's another thing we're going to find today, and that's the splanchnic nerves. Splanchnic nerves. Okay? If you look at an X-ray here, the different compartments highlighted. When you're explaining an X-ray to someone, you want to be able to identify, I see a mass or a widening in the superior mediastinum, or there's something suspicious in the anterior inferior mediastinum. You want to be able to talk intelligently about these compartments. Okay? If we look at the superior mediastinum, and what we're going to do is we're going to go through deeper and deeper layers here. The first thing you do when you opened the cadaver yesterday, there was one cadaver that was sitting right there on top. That would be the brachiocephalic vein. Who had that cadaver? Three? Okay. Very good. They have this perfect anatomy right here. They've got the right brachiocephalic vein draining the right side of the head and the right upper extremity, and the left brachiocephalic vein, and you can see their left internal jugular joining the left subclavian. Did you guys mess it up or just leave it? No. Okay. All right, so I want you to leave that one right there because everybody, you need to understand this relationship. And you see it's sitting on top of the pericardium. Now they open the pericardium here, but it's sitting on top. It's outside the pericardium, right? Those two brachiocephalic veins come together to form the superior vena cava. Superior vena cava. There's a whole bunch of syndromes related to the health of the superior vena cava. We discussed one of them yesterday, and that would be a tension pneumothorax. You can see where it would be easy for that tension to put pressure on that big vein and stop venous return. No venous return, no arterial output. So, okay. Also in this illustration, you see the pericardial fat. We saw plenty of that yesterday on a couple of the cadavers. If we open up a window in the pericardium, which is what we're going to do today, what you see immediately is over here on the right side is the right atrium. On the left side here, did I say left atrium?
You said
It's the
that
right atrium. What you're going to see right here is the right ventricle. The very tip right here, forming this border of the heart, is the left ventricle. You'll see it in a little bit, but mostly what you're looking at here is the right ventricle. Now, the surface of the heart is covered with fat. So you'll need to take like a scissors or pickups or something like that. And if you just rub it like that, the fat kind of just peels off. It just comes off like butter. Okay. All right. Up here at the top of the superior mediastinum, you'll see the right vagus nerve as it crosses anterior to the right subclavian artery, right there. And, excuse me, brachiocephalic trunk, not the subclavian. Well, no, it's the subclavian because it's giving off the common carotid, so it's the subclavian. And over here on this side, you're going to find the phrenic and the 10th nerve. I think somebody found it, Kim, did you guys found it yesterday, right? On the left side, they're pretty easy to find. Now, the thing here that you need to pay attention to is the phrenic is going to go all the way down to the diaphragm. The vagus dives deep to get onto the esophagus, so it sort of stops right there on both sides. You can't follow it very far because it dives down onto the esophagus. All right, any questions? Okay. Here's a picture of the thymus gland where it would sit in a kid. It can be quite large, and it is superficial, very superficial. In your cadaver, there was one of the cadavers in there yesterday. You guys had just a clump of fat up here. That was the remnant of the thymus gland. As it involutes, in your teenage years, it's just replaced with fat. And that's what your cadaver had. Meredith? Yep. Okay. All right. Now here are the internal thoracic arteries here. If there's any question about the relationships that I'm throwing up here, fire away. All right, so what we're going to do here is show you, there's the thymus gland. You see how wide it is in this little kid? How much it widens out the superior mediastinum. If you saw that in an adult, you would be alarmed. But in a kid, well, here's the adult right here. In a kid, it's normal. This structure you see here going up and over and coming back down, that happens to be the aorta. Okay. Now, if you go a little deeper into the superior mediastinum, the four nerves up here become more apparent. You got the two vagi, and you have the two phrenic nerves. You start to see the brachiocephalic trunk, and there's the left common carotid. All right. Now, what I want one of your tables to do today is, while somebody's cleaning up the heart, another team of people, I want you to dissect into the superior mediastinum to be able to see these different structures. The brachiocephalic vein people, y'all leave yours alone. But the other ones start going a little deeper. And then you're going to go even a little more deeper. And you're going to get down here to the trachea. See, we've had to cut the arch of the aorta. There's the aorta coming up and over behind the left brachiocephalic vein. We had to cut the aorta out, and we've cut the brachiocephalic artery. We've removed the superior vena cava and the brachiocephalic veins to get down into this deep area. This is the pulmonary trunk dividing into the right and left pulmonary arteries. You have four pulmonary veins that drain the lungs. And then you get down to the trachea, and you can see there's our carina and our left and right main stem bronchi. The descending descending thoracic aorta is here, and right beside it to the right is the esophagus. The esophagus is going to look like a brown muscle with
muscle fibers running vertically, okay? It's very nondescript looking, and I've had people just rip it out thinking it was doo-doo, and it was the esophagus. So don't rip the esophagus out, okay? Oh, I want to show you something. You see, here is the left vagus. Now, back when you were a little bitty fetus, you didn't need your lungs to oxygenate your blood, right? Because your mama did that through the placenta. So why do you send blood to the lungs from the heart? What's the purpose? It's not for oxygenation. Why would you send all this blood out of the pulmonary trunk into the heart, into the lungs, right? So instead of doing that, let's shunt the blood from the right side of the heart, which is what's going to give rise to the pulmonary artery, and let's shift it over into the left side of the circulation, which is the left ventricle that supplies the body, right? It's a right to left shunt of blood. Back when you were a little fetus, there was a structure here that as soon as you're born, it collapses on itself and becomes a ligament. In an adult, it's called the ligamentum arteriosum. It's the remnant of the old connection between the pulmonary trunk and the arch of the aorta called the ductus arteriosum. Back when you were a fetus, it was called the ductus arteriosum because it was a duct. So blood destined for the lungs would get shunted through that duct into the systemic circulation and bypass the lungs. When you were born, there was a complete shift, where there was a huge shift in your blood flow because of pressures, because now your lungs are inflated, that winds up causing this duct to sclerose down and become ligamentous. So in you, it's just a band of tissue. Now in some children, this thing will persist. It stays open. That's called a PDA, a patent ductus arteriosus. PDA. So when they're born, they're shunting blood from the right and left. They're not oxygenating their blood, and they can become hypoxic. It's also, when you put a stethoscope on a newborn, you want to make sure you don't hear a heart murmur in this area that would signify that you have a PDA. Interestingly, all you got to do, these things are prostaglandin derived. Prostaglandins keep it open. All you got to do is give them an NSAID, like Motrin, and that blocks prostaglandin synthetase, and it typically closes with an NSAID. If it doesn't close, if it's severe enough, they have to surgically close it. A PDA. That's your landmark for finding the left recurrent laryngeal nerve. It goes up under the ligamentum arteriosum. Very easy to find. You follow the vagus down, and you'll see that branch headed under that ligamentum arteriosum. The recurrent laryngeal is headed back up to go to the larynx, right? Okay, for those of you that frequent hookers, I'll give you a bit of advice. Syphilis, untreated syphilis, has a tendency to attack weird parts of the body. One of the parts would be the spinal cord, producing a goma. And I think we were talking about that, the proprioceptors. Another place that syphilis, the bug, attacks is the arch of the aorta. And here's an example of a syphilitic mass in the arch of the aorta of clearly a dead person. But here's the thing. If that syphilitic invasion of the arch of the aorta occurs, it can damage the left recurrent laryngeal nerve. What do you think is going to happen if that's the case? Well, you can still talk because the right side's working, but the left side's not, so you'll be hoarse. You know, one side of your vocal fold will be paralyzed, and you'll be hoarse. So don't be with a hoarse hooker. That's the take-home message of the day. Okay, Larry? Wait a minute, Brock's the one I gotta worry about. At 1:16 in the morning. Any questions about this?
I think your wife would appreciate that.
Oh, you're married. Oh, you're married. Come on, get her on the phone for me. All right, so here's the ligamentum arteriosum illustrated for. You need to know this relationship. You need to be able to identify all these branches here. One of the cadavers go deep on this dissection, and let's see all of this stuff, including the bifurcation of the trachea. All right. Finally, we get all the way down there, and this is what you look like. You see the right main is straighter, wider, and shorter than the left main. You ought to be able to recognize that. Over here on this side, this is everything put together. You should know this. You should know this. You should know these relationships of what sits on top of what wraps around what. That would be a good thing to understand. All right. The inferior posterior mediastinum, since there's not much in the anterior, there's not much in the middle, there's a whole bunch of stuff in the inferior posterior, and this is what you see here. Let's look on this side first. Here's our hilum of the lungs that we cut yesterday. You're going to see a vessel. Oh, let me back up. That opening right there. I want you to pay attention to that. The way you drain the intercostal veins is through this system called the azygos system. The azygos vein drains right here into the superior vena cava just before it gets into the heart. So the three things that go to form the superior vena cava are the two brachiocephalic veins and the azygos vein. If we cut through here, like in this previous illustration, that's the opening of the azygos vein right there, coming into the back of the superior vena cava. You see that relationship? Coming into the back of the superior vena cava. If we cut the superior vena cava out, we still got the azygos vein coming into it. All right, so this is the azygos system of veins. This is on the right side, and the right side only. Next, you'll see the intercostal artery and nerves. They're very apparent. I think Kim, didn't your group find Annie, your group got that? So you'll need to find that. Right here at the, beside the vertebral bodies, and this is where the vertebral bodies are right here, you're going to see the sympathetic chain with its ganglia at each level and the rami communicans connecting it to the spinal nerve, or to the ventral primary ramus, not the spinal nerve. It's very apparent. Do you guys find it here? Yeah. Are you in the same group? So this group over here has already found it, so you need to take a look at that. All right. Here's the esophagus right here, and there's the that's the esophagus right there. The aorta is on the other side. So if we look on the other side, here's the arch of the aorta coming up and down. This is on the left side, the left cavity. We have the same pictures. We have the sympathetic chain. There's the phrenic nerve. There's our vagus nerve. Do you see the vagus nerve diving down through there? Right there? What it's going to do is it dives down through here, and there's the esophagus. It forms a plexus around the esophagus. So the right and left vagal nerves, once they enter the chest cavity, if this is our esophagus, they form a plexus around the esophagus. And then just before the esophagus goes through the diaphragm, they reform into an anterior and posterior vagal trunk. So as it forms this plexus here, it's giving off nerve fibers to the esophagus, to the heart, to the lungs, okay? One more nerve I want to show you is coming off of the sympathetic chain ganglia. You'll see these branches that go onto the top of the vertebral bodies. They're directed medially, right here and right there. Those together form the splanchnic nerves. And they come off of all of the chain ganglia from T5 all the way down to T12. And there's a greater, a lesser, and a least splanchnic nerve. A greater, lesser, and least splanchnic nerve. Now here's the thing. Pay attention to this. Remember I said that concerning the sympathetics, the cell bodies, or the post-ganglionic cell bodies that were going to the target organ, were either found in the chain ganglia, like those of the heart. Remember the nerves off of the chain ganglia come down to the cardiac plexus that go to the heart, right? Or the pre-aortic ganglia. We haven't seen them yet, but they go to the pre-aortic ganglia. What goes to the pre-aortic ganglia? It's the splanchnics. The splanchnics are going to go through the diaphragm and provide the sympathetic preganglionics going to the pre-aortic ganglia. And from the pre-aortic ganglia, they'll just catch a ride on a blood vessel, from the renal artery out to the kidney, on the superior mesenteric out to the stomach. Okay? I mean, not to the stomach, to the colon. Okay, so you got a greater, lesser, and least splanchnic nerve coming off of each side. You're not going to be able to distinguish those at this point. Just know that the fibers coming off of the chain ganglia going medially will go to form the splanchnic nerves, the thoracic splanchnic nerves. Okay. Finally, on the left side, you still have an azygos system, but it doesn't drain directly into the superior vena cava. What happens here is the top six intercostals drain into what's called the accessory hemiazygos. The bottom six intercostals drain into the hemiazygos. These two drain over, they cross the midline and drain into the azygos. I'll show you a picture here in just a second. Well, quick second. Here you go right here. Here are the intercostal arteries. They're all branches off of the aorta, little branches. You do have the supreme thoracics coming off of the axillary, like we talked about last week. Over here is the azygos system. So here's the azygos vein draining into the back of the superior vena cava. Here's the hemiazygos draining into it, the accessory hemiazygos draining into it. So the chest cavity drains into the into the azygos, which then in turn drains into the superior vena cava. See, the problem is you don't have veins draining directly into, like the superior inferior vena cava. Intercostal vein doesn't drain directly into the caval system because you got this heart in the way. So they got to go around the heart through this azygos system. There's one other thing I want to point out is the azygos vein also drains into the inferior vena cava down here. So there's a connection both above and below the heart. And blood can drain either way in the azygous system. Depending on your position. Next week, we're going to talk about liver failure, where the direction of venous blood in this system goes will become important. So that's why I point out that the azygous system can either drain into the superior or inferior vena cava. And you need to see in lab that azygous vein. Somebody find, probably you guys will have a good azygous vein. So,
Body 4 has it, Chad showed us yesterday.
okay, good, body 4. Okay. All right. Did he talk about the azygous system? in terms of-
Yeah, he was
He
telling
showed
us all
us.
kinds of stuff
Yeah.
that you hadn't talked about yet.
Well, good. Yeah, I know he was throwing out a lot of abbreviation about the coronary arteries, and well, we're gonna do that today, so. He's gonna be there this morning, so. All right. The lymphatics. Here's the thoracic duct. We've been talking about that damn thing for 3 weeks now. Here, you're gonna find it today. You're gonna find it in the chest. Now, when you take out your heart today, let me explain that. You're gonna take out the heart. What you're gonna do is open up the pericardium. And you're gonna reach behind there and feel the connections of the great vessels to the heart. They're on the top and in the back. Then you're gonna reach back there with a pair of scissors and you're gonna cut those connections, or you can do it with a scalpel, and then you're gonna remove the heart. So you're gonna be looking into the pericardium, the back of the pericardial sac, right? Now, you're probably gonna have to tear through that to get down to these posterior mediastinal structures. The more you clean it out, the better access you're gonna get to this. But between the azygous vein on the right and the arch of the aorta, there's a tiny little channel called the thoracic duct. It's thin-walled like a vein, and you can rip through it kind of easily, and it won't be any bigger than a pencil. Now, it starts down in the abdomen as a structure called the cisterna chyli. Something like that. Cisterna chyli. So all the lymphatics from your body, from your viscera, drain into that cisterna chyli. And then the lymph flow goes up and around to drain into the thoracic duct at the junction of the internal jugular vein on the left, and the left subclavian vein. You guys can probably find that thoracic duct. It comes up and joins the back side of it. And it drains all of the lower half of the lower part of the body and the left side of the head and the left upper extremity. All of that goes into the thoracic duct. Now on the right side, you also have a lymphatic channel that drains into the same place. However, it only drains the right side of the chest wall, the right upper extremity, and the right side of the head. It's much, much smaller.
What does?
On the right side. You have the same duct on the right side. It's just small because it doesn't drain that much body surface area. Also, the left side is draining the viscera. There's a lot of nasty stuff going on in your colon right now. Okay. Ms. Sears. Okay. Any questions about that? Okay. So somebody, the thoracic duct is very easy to find right here. You know, last night when I was reviewing this, I don't know why I put this slide here, but it looks kind of nice. You can see the greater splanchnic nerve getting ready to go through the diaphragm there, but I don't know why the slide is in that position. So we'll go to this. Okay. Now, the pericardium, back when you were a little bitty embryo, your heart started growing into the pericardial cavity, kind of like your lungs did, all right? But I say kind of like, it's a lot different because your heart started out just a straight tube. And then, but you have 4 chambers. So what happened was the tube folded, and then a divide came between the two. Now you got 2 chambers, and then it folded again, and now you got 4 chambers. That's a very simplistic view of it, but that's what happens. Your heart started out as a straight vessel that folded to form the 4 chambers. Also, the straight vessel, the 2 ends of the vessel started dividing off to form the great vessels. Embryologically, the folding of the heart and the creation of the great vessels, just an amazing series of events that happened right there around probably week 5, 6, and 7. So, it's really impressive. Anyway, as this thing is growing into this cavity, you're left with this structure. The surrounding membrane of the heart is called the pericardium. The outermost layer that you were looking at yesterday is called the fibrous pericardium. It's a gray, dull membrane that does not give. There's no elasticity to it. If you tried to pull on it yesterday, it didn't stretch any. So that's the fibrous pericardium. Now, as the heart grew in there, there's you see the membrane on the inside? So then the heart winds up growing into that membrane and forms 2 layers with a pericardial cavity in between them. The 2 layers, the first one from the outside, in other words, it's attached to the fibrous pericardium, is called the parietal layer of the serous pericardium. The parietal layer of the serous pericardium. It goes up, and where the great vessels are, it's going to reflect onto the surface of the heart. So the outermost covering of the heart is called the visceral layer of the serous pericardium. Everybody got that? All right, so the pericardium has 3 layers. The fibrous pericardium, the parietal layer of the serous pericardium, and the visceral layer of the serous pericardium. With these, between the serous and between the visceral and parietal layers of the serous pericardium is the pericardial sac, or cavity. Now, because you have more than one great vessel, this is what you're going to see today. You got the inferior vena cava, you got the 2 pulmonary veins, there's your pulmonary artery, there's the aorta. This you're looking at here is going to be the parietal layer of the serous pericardium. It's the inside layer, right there. Out here is the fibrous layer. Where's the visceral layer? It's on the heart. The connections between the visceral layer and the parietal layer, though, occur at these great vessels. And you'll see that cut margin there. There's another cut margin there. You have to cut that reflection in order to get the heart out. So the orientation of these great vessels and these reflections creates this backward 7, up and over. You see that? All right, so if you were to put the heart back in there, understand that if I take my hand and try to wrap it around the heart this way and put my hand up into there, that's, by the way, called the oblique sinus. That's the back of the heart. I cannot push my hand up or over because of these reflections. You follow me? Now, the other thing I can do is if I take my left index finger, I got my hand behind the heart here, I take this index finger and run it behind the great vessels up here. In other words, I come in up here. That's called the transverse sinus, which is above that part of the backward seven. You see my fingers behind the great vessels here, right? So I've got this finger in here and this hand back here. They won't touch because of this reflection. You see that? Now, you might think, that's a stupid thing to be talking about. Who really cares? Cut the heart out. Well, it sort of matters. Ask Chad if knowing this relationship is important or not. Okay? Understanding the reflections of the visceral and parietal serous pericardium, very important. Okay?
So would fluid from those two sinuses communicate in front?
They would, yeah. They would communicate around the heart where you stuck your hand in here. Yes, you could certainly wrap your hand around like that. Okay? So when you make the window in your pericardium today, try that. So you can understand the sinus relationship there. Okay? Or at least stick your hand behind the heart and try to push it up and try to push it over. Can't do it. Well, okay. Let's say we have, we've hit the steering wheel in our MVC, motor vehicle collision. They're not called MVAs anymore, motor vehicle accidents. They're called MVCs, motor vehicle collisions, because MVA indicates that somebody's liable. So the lawyers have now changed the medical terminology to MVC. You've been in an MVC, not an MVA. Okay? Believe it or not, that's true. You got a big blunt force trauma to the chest, or you were roofing and you fell off and you hit your chest on the pavement. You ruptured vessels on your heart. You're bleeding into your pericardial cavity. Where is it going to go? Nowhere. Where is it going to stretch to? Nowhere. The fibrous pericardium will not let the pericardium stretch. So what happens is, with every beat of the heart, more blood enters the pericardial cavity. So as more blood gets into the pericardial cavity, the heart contracts, and then more blood is out there, it can't relax. So the more blood that fills it up, you wind up with no relaxation. End diastolic filling. Diastole is when the heart is at its maximal relaxation, right? End diastolic filling goes down. If end diastolic filling goes down, cardiac output goes down. If you can't squeeze anything out of the heart, but yet your heart, the electrical activity in your heart is going along just fine, but I feel your pulse. If you have no pulse, what did I say yesterday that was? PEA, pulseless electrical activity. Cardiac tamponade is what that condition is called. When you have fluid around the heart that's restricting cardiac output, it's called cardiac tamponade. It is another major cause of PEA. The way you fix that is you take a needle and you stick it through the diaphragm into the pericardial cavity and draw off blood or malignant fluid, whatever happens to be causing the fluid in the pericardium. And by the way, in terminal cancer patients, this is one of the big problems, is they wind up with an effusion because of malignancy. There is a way to permanently treat this. If you keep rebuilding fluid in the pericardium, they'll go in there and cut a window in the pericardium so that it just drains out. into the thorax. Okay? Yes, ma'am.
So after you do that, would you have to start blood transfusions? Because.
Well,
blood's
if
just
they're
draining
bleeding out, yeah, you're gonna have to, any time you have trauma like that, you're gonna start 2 large IVs. You're gonna give them fluid, you're gonna give them blood, you're gonna give them things called pressors to increase your pressure, so, yeah. But if you have tamponade, what you're gonna have to do is get to the OR. One thing about this is, one of the telltale signs of cardiac tamponade is when you put your stethoscope on the chest, and if there's fluid in the pericardial sac, what's it gonna do to the heart sounds? It's gonna muffle them. You're gonna be, distant or muffled heart sounds, because you got all this fluid around the heart now. The other thing is, when you record, you do an EKG on somebody, you put the electrodes on the chest. And what are they doing? They're picking up the electrical activity in the heart. Well, let's put a bunch of fluid between the heart and the surface of the chest. And then what happens is you're going to get low voltage, a low voltage EKG in all leads. There are 12 different thing called leads here. They're all low voltage. Muffled heart sounds, decreasing blood pressure, increasing heart rate, low voltage EKG. You better stick a needle in them. Now, you can quickly do a bedside ultrasound to demonstrate the fluid around the heart. That confirms it for you. You can see it on the CT here. There's a lot of fluid around the heart. And on a plain film here, it's characterized by a widened heart shadow, an enlarged heart shadow. You'll see that heart shadow is about probably 3 times the normal size, because it's the pericardium we're looking at, full of fluid. Layers of the heart, there are 3 layers of the heart. The outermost layer is the visceral layer of the serous pericardium, also called the epicardium. The muscle of the heart is called the myocardium, and in the inside of the heart is called the endocardium. The inside of the heart is just like the lining of the inside of a blood vessel. It's 1 cell layer thick, but that's called the endocardium. The heart borders, if you put the heart into the chest, recognize that the right heart border is formed by the right atrium. The left heart border is formed by the left ventricle, because the left ventricle sort of wraps around to form that left heart border. So if you're looking at a chest x-ray, a normal chest x-ray, this would be the right atrium, that border would be the left ventricle, if it didn't have fluid around it. Okay. This is the apex of the heart. So the apex of the heart is out here. The part of the heart where the great vessels are is called the base. The base of the heart, apex of the heart. When you're listening for heart sounds in physical diagnosis, if you take a slender person and I'm going to come back to my man here. Can you stand up again? So if you take a slender person here, I'm going to, right here, right there, right there, I can feel his heartbeat right there. That's the apex of the heart. It's in the 5th intercostal space at the mid-clavicular line. You can feel his heartbeat right there. If you're lying down and you get a thin person, if they're lying down, you can see it bump against the skin. You can see the pulse on their skin right here. Okay? easier to see on guys because you don't have this breast thing in the way. But, there are two, you know, the four chambers of the heart. You got the right atrium, right ventricle, left atrium, left ventricle. You should know that off of the right and left atria, there are these little ear-like flaps called auricles. Each atrium has an auricle. You want to be able to identify that today. You also need to appreciate the blood supply or the blood flow through the heart. And that's what this very sophomore childish illustration shows you. You've got the superior vena cava and the inferior vena cava. Inferior vena cava has a little valve on it you'll see today. They drain into the right atrium. They go through the atrioventricular valve or tricuspid on the right side of the heart into the right ventricle. You got the pulmonary trunk, has right and left pulmonary arteries into the lungs, comes back 4 pulmonary veins into the left atrium. The left atrioventricular valve is the mitral valve. It's a bicuspid valve, has 2 leaflets into the left ventricle and then out the aorta. There's a valve at the aorta called the aortic valve and a valve at the pulmonary artery here called the pulmonic valve. We'll go through each of those in just a second. But that's the course of blood through the heart. The coronary vessels are the first 2 vessels off of the heart. Off of the aorta. It's not the brachiocephalic in the left common carotid, it's coronary arteries. There's a right and left coronary artery. The left coronary artery, here's the aorta right here. The left coronary artery, well, before I go into that, let me tell you about 2 depressions or grooves. There's a groove that separates the atria from the ventricle, from the ventricles. There's a groove there. That's called the coronary sulcus. The coronary sulcus separates the atria from the ventricles. And then there's another groove that separates the ventricles. It's called the atrioventricular sulcus. In those sulci, that's where you'll find the vessels. So, the left coronary artery comes out, and then it comes around from the back side of the heart onto the front side and divides into a circumflex branch that will go onto the back of the heart in the coronary sulcus. It follows the coronary sulcus onto the back side of the heart. The other branch is called the left anterior descending, the LAD. Chad yesterday, he kept saying LAD, LAD, LAD. When he was talking about bypass surgery, the radial artery and the internal thoracic, we're going to hook it into the LAD. So if this is the most commonly blocked area in atherosclerosis, so this is the most commonly bypassed area. They would take that internal thoracic artery and tie it into the artery distal to the blockage. That's the bypass. Frequently called a CABG, coronary artery bypass graft, CABG. The LAD comes down to the apex of the heart in the interventricular sulcus, and then will head over onto the backside of the heart. Now, the right coronary artery comes out of the surface of the anterior surface of the heart, travels down the coronary sulcus. It gives off what's called a nodal branch that goes to the pacemaker of the heart. Nodal branch, call it nodal artery. Continues in the coronary sulcus and then zips around to the backside of the heart and will anastomose with the branches from the left. So it'll pick up with the circumflex here, and then it'll give off a branch that will anastomose with the LAD. right coronary also gives off this right marginal branch. This applies to the inferior surface of the heart. This table right here says if you block an artery, one of these arteries, it will produce a myocardial infarction at that location. For example, if you block the LAD, the part of the heart that's going to die is going to be the anterior part, or the septum dividing the right and left ventricles, or the lateral part out here. Those three areas are affected in blockage of the LAD. If you block the right marginal, you're going to have an inferior infarct. Right, it says right coronary, but if you did the right marginal, it's inferior. If you blocked it up here, same thing, inferior and posterior. Right? The circumflex is going to be anterior lateral or posterior lateral. The circumflex is going to be anterior lateral or posterior lateral. And if you block the right coronary up here, and it affects the nodal, you're going to have rhythm disturbances because it's going to affect the pacemaker of the heart. On an EKG, you'll learn this later on, you can look at an EKG and determine what vessel is blocked. It's very apparent. Okay. All right. Here's an example of coronary angiography. What they do is they run a catheter from your femoral artery all the way up into your right, into the opening of the coronary arteries on the aorta. And then they squirt a little material that is radio opaque. In other words, it shows up on an x-ray. They do what's called fluoroscopy. So instead of an individual film, it's like a video. And you see the vessels filling, and you can see defects where there's the LAD, and all of a sudden it stops. They go ahead and put a stent in there to open it up and restore the blood flow through the artery. That's how stents work. Okay, it's amazing that they can get that stent. They can snake that scope, or they can snake that wire into the coronary vessel. That's how directional that thing is. Pretty impressive. Okay? You can see right here where when they're talking about occlusion of coronary arteries being percentage-wise, this is an example. You got a 99% blockage there. You still got a little filling past the defect, but there's not much. Okay, you would definitely want to stent that. People wind up with 1, 2, 3, 4, 5 stents in their coronary arteries to avoid a CABG. By the way, a stent will cost you about $12,000 a piece. So that's just the cost of the stent. The cost of the putting it in is about 10 times that. So, oh no, not 10 times. Maybe 5 times. 4 times. It's a lot.
Does the placement of a stent increase the chances of plaque buildup? Does it give something for it to?
The early stents that they put in there were just mesh, expanding mesh. They put it in, it expands. Now they have stents that are coated with a drug. They're called drug-eluting stents. That drug leaching out of the wire prevents them from clogging back up. Although, that's always a potential complication of the stent is restenosis. And once you put a stent in, you're kind of stuck with it. You can't go take it out and you can't put another stent on top of it. So, if things mess up, it usually requires a cabbage.
So from this slide and even the one before this, the right and left coronaries both come out anteriorly, or one of them turns and comes?
Now, if I'm looking at the heart, if I've got the heart right here, if I'm looking at the anterior surface of the heart, and there's the aorta coming out,
Yeah.
the right coronary comes out right here. It's on the anterior surface. The left coronary you'll find around the back, but it wraps around
Okay.
to come anteriorly. And you want to find all these vessels on your heart. Now, if you get in there and people have had bypass surgery, you're going to get some screwy vessels, and you'll know right quickly that, oh, this person had bypass surgery. Did anybody have a suture line here in the chest? Okay, so maybe there's nobody with bypass. The veins of the heart, some inspired anatomists came up with these stupid-ass names for the veins of the heart. The one that runs in the anterior sulcus is called the great cardiac vein. The one that runs along with the right marginal is called the small cardiac vein. The one that runs in the posterior interventricular sulcus is called middle cardiac vein. The three of those drain into this structure in the back called the coronary sinus. That's the name of that vein right there. Coronary sinus drains into the right atrium. Coronary sinus drains into the right atrium. Actually has a little flap valve over it. You'll see it when you open up the right atrium. The veins that drain the anterior part of the heart, they're called anterior cardiac veins. Don't worry about finding these. Now these veins here are very thin walled, so as you're trying to clean out to find the arteries, most of the time you rip these apart. And that's okay, but understand this anatomical relationship. All the veins of the heart, significant veins, drain into the coronary sinus, and that in turn drains into the right atrium. Let's take a break and then we'll go over some other stuff.